As we know, pediatric forearm fractures have been historically managed conservatively, but redisplacement or loss reduction has been the most common complication, which leads to malunion or failure of treatment. And moreover, the remodeling is less predictable after 8 years of age. Hence, there has been an increase in the operative management of the pediatric forearm fractures. In past 2 decades, multiple studies have been conducted to know these factors. These have been mainly classified into fracture-related, patient treatment or surgeon-related, or patient-related factors. But previous studies have been mostly retrospective. They didn't include all factors held responsible and had incoherent results. To assess the cast quality, various objective factors, various casting indices known as radiographic indices have been given up for objective assessment of the cast quality. In our study, we have included 3, and they have the most commonly used one, namely cast index, 3-point index, and the second metacarpal radius angle. Cast index tells us about the interosseous molding. It has a cutoff of 0.81, and it is a ratio of the sagittal cast width by the coronal cast width. The second index which we considered is a 3-point index. It is based upon the Charlie's 3-point fixation. It is only for distal metaphyseal fractures, and it has a cutoff of 0.8. It is a complex ratio which considers the molding of apart from the fracture site, also considers molding proximal and distal fracture site, and also considers the qualitative reduction. It's a very complicated ratio as it is shown up by the equation. The third index which we consider is the second metacarpal radius angle. It's the angle between the second metacarpal and the shaft of the radius. It should be more than 0 degree, and it is only used for the distal metaphyseal fractures. Fracture obliquity angle is the maximum obliquity of the fracture site, which is considered only for distal fractures. The greater the out of the 2 great obliquity angle in AP and lateral view, one is considered to be the fracture obliquity angle for that particular patient. The research question for our study was, what is the rate of redisplacement requiring remanipulation, and what are the risk factors responsible for redisplacement of pediatric forearm fractures managed conservatively. It was conducted from October 2011 to March 2013 with 113 patients. Age of 2 to 13 years of patient of either sex were included, with a closed forearm fracture of less than 7-day-old, which required close reduction. Patients which failed to achieve primary close reduction, physeal injuries, closed physis, torus fractures, segmental fractures or pathological fractures were excluded. Associated distal neurovascular deficit, joint dislocation, and associated fracture in the same extremity were excluded, along with the non-willing or non-compliant parents. So the factors which were studied were fracture related or treatment related. Pre-reduction fracture displacement, fracture obliquity angle for distal fractures, site of fractures, and the bone involved were the fracture related factors, while treatment related factors included the quality of reduction, the surgeon's experience, whether he was a trainee orthopedic surgeon or a qualified orthopedic surgeon, injury to cast interval, and the casting indices, which I have discussed previously. So all patients which were satisfying the inclusion exclusion criteria were given an attempt of close reduction with above elbow POP cast under cautious sedation by a doctor on duty. If he had acceptable reduction, he was followed up weekly in OPD for next 2 weeks. If he had unacceptable reduction, he was given another attempt of close reduction under general anesthesia. Now, if he had an acceptable reduction, he was followed up as in the previous group. But if he failed to have acceptable reduction, he was operated and was excluded from the study. At 2 weeks, another X-ray was done to look out for redisplacement. If the reduction was maintained, the patient was followed up weekly till union. If there was redisplacement seen at the end of 2 weeks, the redisplacement was seen whether it was acceptable or not. If it was acceptable, it was followed up till union. If it was not acceptable, patient underwent remanipulation. If he had an acceptable reduction after remanipulation, he was operated but included in the study. But if he failed to attain an acceptable, if he achieved acceptable reduction, he was followed up with the other group. In the end, a comparison was made between the patient with significant redisplacement and patient with which were acceptably reduced. To eliminate the confounding factors, subgroup analysis of distal fractures was also done. Total 113 patients were seen. 76 had diaphyseal fracture, but 37 had distal metaphyseal fractures. 13 patients had significant redisplacement, only 10 underwent remanipulation. Mean age was 8.62 years. There was no association of age, sex, level of fracture, site of injury, number of bones fractured, injury to cast interval, or surgeon's experience. Pre-reduction angulation had no role. Complete displacement in any plane in either of the 2 bones was highly significant predictor of redisplacement.
Kindly conclude.
Go ahead. 1 minute. Go ahead. Because you got plenty of slides.
Yes, sir.
So many.
Complete displacement in any plane of either any of the bones was a highly significant predictor. The fracture oblique angle of more than 20 degree was a significant risk factor. Post-reduction angulation of more than 10 degree in any plane in any of the bone was a highly significant predictor of redisplacement. Casting indices were found to be significant predictors of all three casting indices in both the groups. This is one of the example in which patient having a casting index more than above the cutoff values had a significant redisplacement, was not acceptably reduced after remanipulation, so was operated and achieved a union. While this patient of a 12-year-old child with diaphyseal fracture had a below cutoff casting index value, had no redisplacement and achieved a sound union. In discussion, the factors responsible for redisplacement are a complete displacement at fracture site and preoperatively, or a fracture oblique angle of more than 20 degrees is a high risk factor for redisplacement. Residual angulation of more than 10 degree after reduction is a risk factor for redisplacement. All casting indices, including cast index and 3-point index, are significant predictor for redisplacement, but 3-point index, being a complex one, should be used only for selected cases. Apart from undisplaced and non-angulated fractures, 3-point index fails in a Bayesian type of reduction, which was first noted in the study. So, conservative management is a treatment of choice in pediatric forearm fractures. All treating surgeons must be aware of these risk factors. They should ensure early identification of cases prone to redisplacement, and casting indices should be used routinely to monitor treatment and cast quality.
Thank you, sir. Any questions? Only 2 questions are allowed from the audience side. No, thank you so much.
Thank you, sir.
Now I'll call.
Only speakers, I suppose.
Now I'll call upon Dr. Lalit Pafna. Lalit Pafna.
Good afternoon, everyone. I am presenting a paper on evaluation of the imprint cytology as an early diagnostic modality compared with histopathology in vertebral lesions. Vertebral lesions include infective or neoplastic conditions. Rapid diagnosis is important for early intervention in both of these cases. Clinioradiological assessment provide only a provisional diagnosis, therefore histopathological diagnosis is must. However, histopathological diagnosis is tedious to perform and it takes time. Therefore, it delays the definitive management. So, therefore, we have a rapid diagnostic methods which include FNSE, frozen section and imprint cytology. However, FNSE has a disadvantage in bony lesions which include difficulty in diagnosing primary bony tumors and cartilaginous tumors. Bone aspirates are heavily blood stained and forceful aspiration and smearing causes breakage and clumping of cells. A frozen section has disadvantage which include it is less useful in hard bony tumors. It is less valuable when submitted specimen is in limited quantity. It creates artifacts, it is expensive and may not be readily available at all centers. Therefore, we have imprint cytology. It is a recent technique successfully used in soft tissue lesions. It is simple, acceptable, reliable, cost effective method for diagnosis. Integrity of the specimen is maintained in entire procedure. Aims and objective of my study is to analyze and compare the result of imprint cytology with histopathology in vertebral lesions in terms of sensitivity and specificity, positive predictive value, negative predictive value and time taken for diagnosis. After ethical clearance and return informed consent, we have included 30 cases of age more than 10 years with suspected infective or neoplastic lesions. These were my exclusion criteria. After noting detailed history and examination, relevant radiological and hematological investigations were obtained. A transpedicular biopsy under appropriate anesthesia with Jamshedi needle is performed. Minimum 2 imprint cytology slides were prepared with the help of biopsy sample. This is how I took a transpedicular biopsy with the help of Jamshedi needle. All slides were stained with May-Grunwald Jimsa method. The core biopsy specimen were prepared for histopathological evaluation simultaneously. Inter-observer variability is nullified by examining all the imprint cytology slides with single pathologist. Imprint cytology compared with biopsy, considering histopathological diagnosis as a gold standard. These were few cases of my study. The 60-year-old male presented to us with the diffuse mid-back pain, X-ray history of multiple lytic lesions, MRI history of hypointense lesion on both T1 and T2. Imprint cytology suggests multiple malignant cells, which was confirmed by histopathology. This is another case, 65-year-old male presented to us with diffuse back pain involving multiple lytic lesion involving multiple dorsal and lumbar region. MRI suggestive of ISO to hyperintense lesion on both T1 and T2. His imprint cytology suggests it is plasma cell, which is found to be multiple myeloma on histopathology. This is another case, a 30-year-old male presented to us with the low back pain with hypointense lesion on T1 and hyperintense lesion on T2 with intact disc spaces. It is found to be malignant cells on imprint cytology, which is confirmed by histopathology. Another case of 35-year-old male presented to us with the low back pain with X-ray history of paradiscal lesion, MRI history of hypointense lesion on T1 and hyperintense lesion on T2. It was found to be a Krejcik's granuloma on imprint cytology, which is confirmed by histopathology. My study design is analytical evaluation of the diagnostic test with sample size of 30. We have included suspected TB spine, 15 cases of suspected TB spine and 15 cases of suspected neoplastic conditions. This is the binomial table from which I calculated my results. By comparing imprint cytology with histopathology, we found sensitivity is 66.7%, while specificity is 100%, positive pectoral value is 100%, while negative pectoral value is 25%. Overall accuracy is 70%. Time taken to report the imprint cytology was 30 to 45 minutes, while time taken to report histopathology was 8 to 21 days. So we have come to the discussion part now. Its accurate diagnosis of vertebral lesions form a prerequisite for initiation of treatment. Clinical examination, laboratory finding and non-invasive imaging studies makes a differential diagnosis of vertebral lesions narrower. However, early initiation of treatment possible only by accurate tissue diagnosis. Imprint cytology emerging as a rapid diagnostic test in evaluation of the neoplastic lesions. Overall sensitivity of the imprint cytology compared to the histopathology was 66.7%, which is comparable with the studies by Joromi et al. The specificity of imprint cytology was 100%. It indicates that it is a good diagnostic tool in confirming cases that are actually free from the disease process. Overall accuracy of imprint cytology was 70%, which depends on the prevalence of disease in a population. A positive predictive value which reflects the probability that the positive test reflects the underlying condition being tested for, which is 100% in my study. A negative predictive value is defined as the proportion of the subject with negative test results who are correctly diagnosed, which is 25% in my case. To conclude that imprint cytology can be used as a rapid diagnostic modality in suspected vertebral lesions of both infective as well as neoplastic etiology with fairly reliable accuracy. Thank you.
Thank you, Doctor. Any questions from the audience side? Any question? Thank you so much. Now I'll call upon the next speaker, Dr. Rajkumar.
Yes, Raj.
Dr. Rajkumar?
Yes.
Meantime, I just want to check whether Dr. Chintan Patel is around or not. Next speaker.
Yes, yes.
Hemant Kumar Agarwal.
Video, sir.
Rajesh Rohila. So I repeat again. Dr. Chintan Patel is not here and Dr. Hemna Kumar Agarwal is not here.
Can I? Yes. Good afternoon. I am Dr. Rajkumar, consultant orthopedic surgeon from Ganga Hospital, presenting on diaphragmatic rupture, a phenomenon not to be missed. As you all know, diaphragm has got three parts: the costal, lumbar, and the tendinous part, and then three main openings: the aortic, esophageal, and the vena cava. The weakest part is the left posterolateral aspect. So, if ruptured, then what happens? The function decreases, the concomitant respiratory dysfunction ensures, and the herniation of the organs happens. So the diaphragmatic rupture was first described by Seneritus in 1541. The rupture was diagnosed by Ambrose Paré in 1579. A polytrauma patient, when comes like this with severe hypovolemia, bleeding and other injuries, the life saving takes priority. So mortality and morbidity is very high in polytrauma patients, and it is also one of the major cause in missed injuries. So in 7 to 66% of trauma, diaphragmatic ruptures are missed initially. So the visceral herniation and strangulation can have mortality rate as high as 40%. So the defect in the diaphragm does not enlarge with time, but it is the volume of herniated viscera that increases. So incidence, it 8% of all injuries, 0.8 to 1.6% of blunt trauma, 10 to 15% of penetrating injuries, and the blunt trauma accounts for 75%. 69% of the diaphragmatic injuries are left-sided, whereas 24% are right-sided and 15% are bilateral. Male to female ratio is 4:1. So the diagnosis remains very difficult and it is often delayed. So how to diagnose? The first thing is a prompt diagnosis requires a high index of suspicion. Clinical signs: patient will have chest and abdominal pain, dyspnea, reduced breath sounds and respiratory failure. The first modality is the chest X-ray, and which is also the gold standard. 33 to 70% of the time we can diagnose by that. The signs are the elevated diaphragm. The abdominal contents once enters into the thorax, and when there is a severe strangulation at the opening, then there is a sign called the collar sign which happens. And also sometimes when there is a nasogastric tube seen in the thorax, then we can suspect that there is a diaphragmatic rupture. The other modalities are CT scan, then the diagnostic peritoneal lavage, ultrasound, MRI, and also laparoscopy. Laparoscopic specificity is almost 100%. So management. Diagnosis itself is an indication for repair. The acute injuries by exploratory laparotomy can be done, and number 1 monofilament and non-absorbable suture is used. Polypropylene mesh for defects of more than 25 centimeters are used. Chronic injuries are best repaired through the chest. Now coming to our experience with the management of traumatic diaphragmatic rupture, we had totally 5 cases, and RTA was the predominant and all were blunt injuries. 4 were left-sided and 1 was right-sided. All cases had associated injuries. The first case, this patient, 24-year-old male college student, was hit by an elephant, and he came to us after 5 hours with severe back pain, and he was not able to move his legs with severe abdominal pain. And this was the initial skeletal survey he showed, and a very unstable spine fracture, and also left if you see his chest X-ray, he has got multiple rib fractures. So because of we did ultrasound and we found free gas in the abdomen, so we did a laparoscopy and found 100 ml of blood in the peritoneal cavity with 3 cm tear in the right dome of the diaphragm. The tear was in the right hepatic flexure. So both the tears were repaired, and thoracoscopy was also performed, and for hemothorax with lung contusion was found. The blood was evacuated, washed, and ICD was inserted. And this is a video showing the right-sided diaphragmatic tear which was repaired through laparoscopic procedure. After the surgery, patient was on ventilator for 5 days. Then the ICD was removed after 10 days. The spine fracture was stabilized after 12 days. This is the second case. 22-year-old female met with a road traffic accident, massive degloving injury of the left thigh. She came with severe hypovolemic shock with tachycardia. Saturation was very less and BP was not at all recordable. Initially, the patient was resuscitated and stabilized hemodynamically. Here, initial chest X-ray itself, which it showed that the left dome was elevated, the breath sounds was absent on the left side. On the management part, initially she underwent the debridement of the thigh, and also the wound cover was done by SSG, and also we did the emergency laparotomy. We found that it was a 15 centimeter long rent in the left diaphragm. The spleen, small bowel, stomach, everything got herniated. Sorry. This is also the video of the patient undergoing the laparotomy, and we found the tear 15 centimeters and all the contents were inside the thorax. And this was subsequently, and you can see the lungs now. And this is the third case where the patient met with a road traffic accident, sustained a grade 3 open femur fracture and also unstable spine fracture. So in this case, patient initially he was debrided, fixation of the femur was done and the wound was closed, and later on the patient was shifted to post-operative period ward, planning to stabilize the spine after improvement in the general condition. But on the next day itself, patient saturation dropped and he was tachycardic. Reassessment of the patient done. Patient was found to have a discomfort in the left upper abdomen. Left side of the chest breath sounds was reduced. Abnormal breath sounds was heard. So emergency laparotomy was performed. Diaphragmatic tear was repaired. Post-operatively the wound improved and the patient saturation and pulse was returned normal. And this patient, the X-ray shows the unstable unstable spine fracture. So do not fall for the obvious, but also look for the other. So there is some mistake. See, in this case, do not. There is this side, the dome of the diaphragm is normal, but this side, if you see, there is a dome elevated so much. So whenever there is a other fractures, so do not fall for the obvious and look for the other small injuries which can be catastrophic. So conclusion: diaphragmatic ruptures injuries may be clinically silent and missed on initial evaluation of the trauma patient. Delayed diagnosis can be catastrophic. High index of suspicion is required to diagnose these injuries. To conclude, do thorough examination with lot of suspicion, necessary investigations to be performed, but also still doubtful, then laparoscopic procedure must be considered. Thank you.
Thank you. Any question from audience side? Only one question. Thank you so much. Now I'll call upon the next speaker, Rikapila Karthik.
Good afternoon, Chairperson and delegates. Thank you for giving me this opportunity. I am from Usmania Medical College, Hyderabad. My topic is a case report on clinically uninfected, infected non-union fracture femur. Purpose of this case report is infected non-union can present even in the absence of any clinical or laboratory evidence of infection. Coming to case scenario, a 45-year-old male patient with a complaints of pain in the left hip and difficulty in weight bearing for 2 years has met with a RTA 2 years back and was diagnosed as comminuted subtrochanteric fracture femur. Primary open reduction internal fixation with recon nail performed at another hospital. The trauma and primary fixation X-rays are not available. This is the present X-ray. Immediate post-operative period was uneventful, patient asymptomatic and partial weight bearing, and had no follow-up with that surgeon. At 6 months, patient sustained a fall on the same hip and the proximal and the distal locking screws were broken. Patient underwent another operation in which a proximal locking screw was applied into the femoral head. The X-ray shows the proximal locking screw which was applied at this instance. Patient had constant hip pain from that period and had never walked with full weight bearing till date. Patient presented to us at this stage. The X-ray shows no evidence of callus at the fracture site. Both the proximal and distal locking screws were broken and the proximal locking screw has penetrated acetabulum. This is the clinical picture of the patient. No sinuses are there, no joint effusion and no apparent muscle wasting. These are the range of movements. Flexion, abduction and the internal rotation are restricted. No fixed deformities were there. This clinical photograph shows that there is no apparent muscle wasting. This is the clinical photograph of abduction and this is the adduction. These are the investigation. ESR and CRP are in the normal range. Montux is negative and blood for culture sensitivity is also negative. This is the bone scan report which shows increased uptake of tracer in the left upper abdomen and upper half of the left femur, suggestive of whole fracture. With the above clinical findings and investigation, a clinical diagnosis of subtrochanteric fracture femur, non-union with implant failure was considered. Plan has been implant removal with exchange nailing and bone grafting. Intraoperative, on opening the fracture site, 500 ml of pus was found and drained. The diagnosis has changed from fracture non-union to infected non-union. Pus drained on the fracture site, debridement done. Removal of the hardware done and the upper tibial pin traction applied. This photograph shows the extracted implant. This is the post-op clinical photograph showing the patient on pin traction. The culture report has been coagulous negative staphylococcus, and the histopathology showed infected granulation tissue with foreign body giant cell reaction. Subsequently, L0 external fixator applied. These are the post-op X-rays. Immediate post-op X-ray showing a lytic lesion over the greater trochanter, and the 2 months post-op, the lytic lesion has decreased and the cortical density has increased. Take-home message is, infection should be considered in painful non-union even in the absence of any clinical or laboratory evidence. Thank you.
Thank you, doctor. Any questions from the audience side? Any other speaker
for this session?
Yeah, can you name?
Rajesh Rudra.
Yes, come on. Rajesh Ohila.
Good afternoon to everyone. My topic is ring versus rail fixated in infected gap non-union of tibia. The infected non-union of tibia, they have so many problems like infection, non-union, deformity, shortening, bone and soft tissue loss. These patient needs to be evaluated for the soft tissue status, infection, joint stiffness, nerve function, vascularity, location and size of defect and hardware. Then we have to decide whether the limb is salvageable or not. The limb should be viable with sensate foot and the patient should be motivated. Then we will go for the reconstruction. The goals of treatment in this are to eliminate the infection, achieve union, restoration of length and alignment, and preservation of optimum functions. The distraction osteogenesis principle can treat these complications, all these complications simultaneously. And my study compares two different types of fixator in this subgroup. There were a total of 35 patients. 20 patients had ring fixator and 15 patients had rail fixator. Both the groups were comparable with respect to the age, sex, mean bone gap and mean size of bone. Proximal corticotomy was done in 17 in ring fixator and in 14 in rail fixator. And 3 patients in ring fixator had distal corticotomy and 1 in rail fixator had distal corticotomy. The surgical technique was remove the hardware, radical debridement of the necrotic bone and achieve a vascularized bed. Remove the bone up to the normal skin. Correction of deformity, then stable fixation by ring fixator or rail fixator, corticotomy, soft tissue procedure as per need. In the results, the mean operating time was little bit more in the ring fixator group, and union was achieved in 17 in ring fixator and 12 in rail fixator. 2 patients in each had bone grafting and 1 in each group had non-union. 1 patient of ring fixator has premature removal of the fixator because of persistent pain. Equinus deformity was more common in ring fixator and superficial pin tract infection were more common in ring fixator. Both the groups were comparable with respect to bone and functional results. These are some of the cases. Ring fixator group. In this patient, I did the acute docking. There are other patients. This patient had bone grafting. In this patient, the complete loss of distal tibial articular surface with about 10 cm loss of distal tibia. So ultimately tibiotalar orthodosis was achieved. There are some other patients. In this patient, I did the distal corticotomy. These are the patient of rail fixator group. In the complications, one patient in the rail fixator had poor regenerate and deformity persisted in rail fixator group. In the discussion, the rail load fixator needs more precision during application to avoid axis deviation or malunion later on, whereas ring fixator can be adjusted. Regarding the management of soft tissues, we can the soft tissue loss can be managed with the help of acute docking, or if you remove the skin up to the if you remove the bone up to the normal skin, the transporting fragment takes skin along with it. The retrospective study and non-randomization were the limitation of the study. In conclusion, the Elizarov method of destruction osteogenesis is a comprehensive approach to all aspects of chronic tibial non-union, and it can address all the problems simultaneously. Soft tissue coverage requirement is decreased. Both fixator systems achieve reliable rates of union and functional outcome. Acute docking at fracture site should be attempted, as it helps in achieving union at fracture site while you are lengthening at the corticotomy site. Railroad needs precision during application, as correction of post-op malalignment is difficult. Patient compliance was better in rail fixator system, and superficial pin traction were more common in this rail fixator.
Thank you, sir.
Thank you.
Any question from audience side? This is end of this session.
So we start with.
Okay, thank you so much.
Right, so we start. आप मेरे संग रहिए, help me. Okay, come on. Are you helping for this? Because I'm all alone. No, but where are they? I need their help right now. Enough from them here. I'll do the job. All right, come. I can manage all alone if no one is there. No one is not picking up the phone. आप promise कर रहे थे कि आप 2 o'clock पे यहाँ पे आ जाएंगे. All right, गुजरात. गुजरात. अच्छा, आप ऐसे करें. फ्रंट रो पे कोई नहीं बैठेगा.
आप आए नहीं हो अनाउंस किया होगा आपका नाम.
मैं बताऊंगा.
खत्म हो गया सेशन.
गुजरात टीम कम है. Come here. They are outside. Forget it. Team 5 Karnataka and Team 6 Haryana. Am I right? Right. Now we'll start with Team 1. There is set of 6 questions. All right. So after first question, the fresh question will be given to 2 and then 3 and 4. So all of you will have the equal chance. That is 1. Now, if you score, if the answer is right, then you will have 10 marks. If it's not correct, it will pass to the another one, and then you will score the 5. If still you are not able to answer it, it goes to the next team. Next team. मैं बहुत फोन लगाया तुमको. Just to start, we have started now. चलिए बैठिए फिर आप लीजिए. पीछे बैठ जाओ वहाँ पे. So, and we are going to give you 40 seconds. I'll ask the organizer, 40 seconds, where is the buzzer? नहीं वो कहाँ गए? He is the responsible person. आप monitor में 40 seconds दिखाएंगे कि आप वहाँ आप बैठ जाइए वहाँ से instead of this आप बताएंगे और 40 seconds will start only after कि वहाँ पे slide आ जाए उसके बाद शुरू होगा. Please organize yourself. I don't know if they can do it or not.
We'll try to put it, but it cannot be.
Maybe they will try. He will. लगा सकते हैं क्या? नहीं इसमें हर बार reset करना वो मुश्किल होगा. अच्छा मैं बताऊंगा ना. He will tell you. This will be very difficult to organize. हाँ ये तो बहुत अच्छा है if you can do this. लेकिन still there could. तो छोड़ दो ना. Please don't do this. Let's not waste time.
He will buzz it.
I'll tell you. Because it is 40 seconds, every 10 seconds, you are in charge. You are the timekeeper. Now every 10 seconds, you'll say 10, 20, 30, 40, stop. But when the question passes to the other team, 40 seconds are not required. Dr. Vineet, 20 seconds?
10 seconds.
20 seconds is enough once the question is passed. Because they already have 40 seconds with them.
Sir, time will start after just starting the question or after
I'll tell you, just to clarify him, the slides are so clear that I need not read the question. Alright? When the slides is put, the timer will start. You will realize yourself, I can speak, but that will disturb you. I don't want to disturb, otherwise, I'll have to read everything and then the time starts. It's all wastage of time. No, I got plenty of rounds. I'll ask you whether you want 6 rounds or 7 rounds. Whatever you decide. 7.
That will decide. The last
6 rounds, raise your hand. No, you will have to start. You have to tell me. 6 and 7 rounds.
7th round is the tie.
I got question up to 8 rounds.
So let's start it now.
6 rounds? 6 rounds is okay? Okay, chalo, 6 rounds.
There's no negative marking for wrong answer.
No. Absolutely no.
3 rounds from this and 3 rounds from this side.
No. We will start from there.
Every time?
Actually, the most important person who should sit down and not stand is the person who is keeping the time. Who is keeping the time?
Sir, I am keeping the time.
You better please sit down.
A few words,
नहीं, आप बैठ जाओ.
from my side also, sir.
Yes.
After 40 seconds, this buzzer will sound, and after each 10 seconds, I'll put a ring on it. That's it.
You want to start each round on same side or is it reverse?
No. It will always move from A, B, C, D, E. Now, who is with mic? वैसे जरूरत तो नहीं है mic की, but mic will not be required.
Should we connect this up?
I'll do it. No, there's one more thing. There's an important. What slide? What can be projected on it? Not the slide one. Whatever. Did I keep something over there? Okay, it's in my pocket. Yeah. So I want all of you to see this. Easy question round, okay? If everyone is set, we can start.
Questions for the audience also?
No question for audience this time because I have got questions, but we have instructions from the organizer that Mr. Shiv Khera is speaking. So why not we all join after the finish? But there is some surprise for all the 6 participants from the you'll see at the end of. So all set. May I know your name?
I am Sanjeev.
Sanjeev? Timekeeping?
Yes, sir.
The first slide is coming and you will start. And the question is to team A. Right? I'm not speaking. 10 marks. Okay? Now, B. What are you looking there? No, don't, please don't. Sorry? No. This row has to be. Who is this person? Question number 2 is coming for the team 2. Ready? So he also scores the 10 marks. Ready? Next team. This is not correct, okay? Team 4, fourth team.
10 seconds left.
Question passes to team 5. I think it's very easy. It's not difficult at all.
Ossification of introsseous membrane.
But diagnosis? No, you're gone. No. Yes.
Fluorosis.
That's correct, yes. Look at the classical more interosseous space membrane. Right. So the first round is over. First round to them is over. Now we come to the team. You have to tell me which team now.
Team 4.
Right? Ready?
4. Team 4.
Ready? Vinith, okay? Capital femoral epiphysis is not correct. Yes.
Distal femoral epiphysis. B.
That's correct. So 5 marks, okay? Now team 5, I suppose.
Team 5. Team 5.
Ready? Okay. Team 6, please.
Absence follicle not first round.
Then we go to the. Vinith, I think we can accept it because whether you call Brody's abscess or maybe tuberculosis with a coke-like sequestrum. Okay, let's allot you. So,
5 marks.
right. So now question goes to.
Team 6.
Ready?
A, sir.
A is not correct. Yeah, I think you're quite confident of your answer. They are right. So first round is over. At the end of the first round, let's know the score.
Team 1 is 20 marks, Team 2 is 10 marks, Team 3 is 0, Team 4 is 0, Team 5 is 5 and Team 6 is 5.
Okay, we come to the round 2 now. And that's the personality round. Actually, I had kept a very difficult round, that is the basic science, but now it is the easier one round off. So, starting from again, team 1 Vinith, am I right?
Yeah.
Okay. Ready?
I think it's again. Should we not start with Team 2 now? Round 2.
Yeah, that should be better.
Right. Okay. Team 2.
Everybody will get a chance.
It's the same thing.
No. First, everybody gets the chance. No. You see, if you pass on the question, passing on the question makes a difference.
Yes.
John, enter.
Nicholas Andre, Britain.
So, I think team C should be given the 5 marks. Yes.
Only the name was asked.
Now question goes to team 3, team C. Ready? Can you identify, if you can identify even 3, it's okay.
So fifth is Sir John Chanley.
Yes,
Fourth is Elisiaro.
yes, right.
Only 10 seconds left. Question passes.
Fifth is Campbell. Campbell and fourth is
Read the name. He's right.
Team 6.
Apple Elijah Chandler. I think that is what this team. You are team number 5, I think. Yes. So they get the 5 marks. That doesn't matter. At least 5th or 6th, 2, and I didn't say that you must tally which faces. I said just name the 3 persons. Why to tally them? Just say Elijah, Chandler, Apple, whatever it is, Catterall. Right.
Sir, so we said 2, then one only from the we get no marks.
No, you will not get marks. He can name all the 3 because he will listen the answer of naturally. Can you repeat the all the 3 names? No. Why to cancel? Yes. Yes. Anyone can repeat it. No. Anyone can repeat it. So next question goes to the team number. Which team? Team 4. Ready? Yeah, you are supposed to know, you know. If you don't know the editor of IGO, then it's not fair. No.
Only 10 seconds left. Question passes.
Team 5. Dr. Tripathi.
Next. Oh, he's right. Yes, that's right. Professor Sudhir Kumar, he's HOD, UCMS and GTB, Delhi. So he's the editor. Many may not know it.
If any team doesn't know the answer, please say pass to just save time.
Now question to the
Team 5, sir.
team 5. Ready?
British.
Next.
Irish.
Right. Who was that?
Team 6.
That's right. Yes, absolutely right. He was Irish. So next comes to you.
No, sir.
Isn't
No,
it?
no, team 6, sir. Team 6, sir.
Ah, yeah, okay, yeah, you're right. Yes, ready?
Gypsum, anhydrate, calcium anhydrate.
Full name, full name.
The chemical name or the
No, chemical name.
calcium sulfate anhydrate?
Calcium sulfate heavy hydrate is the correct answer. That's right. Very good. I don't know you're from which state. Doing well. So is the round over? Second round?
No, sir. Team 1.
Yeah, you're
Team 1.
ready? Should be easy for you. Yeah, I know. I think from Gujarat, no? Originally. So they get the 10 marks. She's in UK, isn't it? So now I think the second round is over.
Yes, sir.
So, Professor Vineet, please. And we start from you, isn't it?
Yes, sir.
Right. So, be ready. This is pediatric. Not very difficult. No, it's not.
10 seconds left.
Yeah, you can utilize your time, full time. Next team. Next. Yeah.
Crab foot department.
Which deformity?
Crab foot.
Club foot?
Crab.
Yes.
Cleft.
trifallism of right thumb with congenital hair loss.
Yes.
Hypochondroplasia.
Yes. Oh, you. No. Okay. And so I think no one has scored. Look at the size over there, no, of the soft tissues. Very big, very mega, very macro. No, it's late, no. So next comes to I think team 4.
Team 4, sir.
Team 4.
Team 4.
Attentive.
B. Autosomal dominant.
Next.
Autosomal recessive.
Next.
X-linked recessive.
No.
Nobody should get answer.
No. I'm sorry. What he said is correct. I'm sorry. Autosomal recessive. They should get the marks. You are team 5. Team 5 gets the 5 marks. Okay. Now it's team 5's turn now.
Yeah.
Team 5. Ready? So have a very careful look there. It's not difficult. I think you can diagnose. Right, you're right. But do you know the further classification? You already scored the 5 marks, but if you can tell some classification also, maybe 10 marks. I know it's difficult, but is the time over for them?
No, sir.
No. Yeah. Still you can think.
20 seconds. Seconds left.
No, yes, sir. Team 6, you can get up.
It was not your turn.
No.
No, it's what we can do?
I think we stop here. Give them.
We stop here. We give them 5 marks. Yeah, 5 marks or 10 marks? We need. Actually, that is the answer.
You said 5, so let's.
5. Let's let it be 5. All right. Yeah. So the next question goes to
Team 6, sir.
team 6.
So, blue sclera and
10 seconds left. Question passed.
Over.
Platy spondylia of spine, blue sclera, hyperlaxity of joints. It is posterior and imperfect.
Yes. So what are the common associated features? Yes, blue sclera. Absolutely right. Yes. What else?
Dentinogenesis is imperfect in type.
They are right. Okay. So they get the 5 marks.
So don't we get 5 for how
No.
the answer? The answer.
But I said 2. Right. So joint laxity also you had said. Now the next question goes to
Team 1, sir.
your turn again. Ready?
What is garage? One would be simple bone cyst.
Time is over.
Time is over.
Team 2.
We will decide the marks, but
Non-ossifying fibroma, simple bone cyst, osteomyelitis, Brodys abscess.
So do name one of how many?
okay, 2. I want 2.
Subacute chronic osteomyelitis.
Tuberculosis.
All right. So the interesting thing is, see, no, let me tell you also, before I allot the marks and also, see the lesion is sitting astride the growth plate. Okay, it is on both the sides. There aren't many lesions which can cross the growth plate. All right, and this is a pediatric age group. So whatever lesions you people are telling may not be correct. There are only 2 correct answers. One given by him. You said
Osteoblastoma. He said osteoblastoma.
no, that's correct. Then probably someone said tuberculosis. So, but only 5 marks to be allotted, not right.
Team 4.
Not 10. Now next goes to
Team 2.
team 2. I think it's easy.
Multiple enchondroma.
Multiple enchondroma. Okay, we'll see. Since they have already answered, so we'll pass.
Hereditary multiple exostosis.
I think that's audience. What do you think? What is the answer?
Hereditary multiple exostosis. HME.
No, you are not the audience. I'm asking. No, you are already told. All right, so that's the correct answer. All right, so they should be given 10 marks.
5 marks. This is pass on question.
Right,
This is a pass on question.
right.
Team 3.
We answered multiple enchondroma. That's the correct.
No, multiple enchondroma is entirely different thing. Absolutely, these 2 are entirely different things. All right. Now, the question goes to
Team 3, sir.
team 3. Ready? It's to you. This is the next round. Okay, is the next round. So the end of these 3 rounds, what is the score?
Next round will go to team 4.
Team 4. But what is the score? Let's know.
Team 3, no. Team 3, you
Team
had
3 started.
Yes, we started with them.
So,
Next.
Gujarat is, sorry, team 1 is 35, team 2 is 10, team 3 is 10, team 4 is 5, team 5 is 20, and team 6 is 25.
25. So team A is leading from beginning, I suppose.
Yes, sir.
So we go to the round 4.
With team 4.
Team 4.
Round 4 with team 4.
And round 4 will start from the team 4, and that is you. Ready?
Peroneal tendinosis or peroneal tendinosis.
Absolutely. I think it's a good answer. Very good answer. I think you're done right. 10 marks for them. The next question to team 5. Ready? Important question.
C14.
That's right. That's right. That's the correct answer. Now on, I'll tell you the reasons also in subsequent slides. Have you allotted them the marks?
Yes.
Next question goes to
Team 6.
team 6. Ready? Correct, that's right. How could you diagnose it? Good, very nice. But why chance fracture? You can read this also. Meantime, I prepare for the
Team 1.
team 1, alright? So you are ready, okay? Most commonly accepted. I know that it varies, but still. See, I tell you, either you don't answer it, you answer at the fag end, and if you answer it, once you answer it, then I will not give you the time. All right. So you're both with the. I'll not tell any comments, but passes to you. He's right. So 5 marks to team B. And this percentage I have taken from the statistics of the most standard AOS. So because I know this could be a bit controversial. All right. Next question goes to team
2.
Your team. Sum up at least 2 findings. Tell me. It's a simple X-ray. Should not be very difficult. If you can tell the 2 findings, radiological findings.